Thank you very much, and very good evening to all of you. And I would like to thank once again Dr. Harry Kishan and Yashoda Hospital and the organizing committee for inviting me. And my talk has been made a lot easier after the previous speaker, Dr. Titiwat's lecture, actually. So there might be some overlap here and there. I know it has been a long day here. It's a great conference and long day, and everyone is tired. So I will try to stick to to the time given to me. All right. Thanks. So the topic is biodegradable stent, or BD stent for short, for TB-associated stenosis. My early experience. The concept of biodegradable stent is not new, actually, in Europe or in the US, but I think it's still new in this part of the world, in Asia. And it has been around for about, for a few years now, I think about 7 years or so from my literature search. So I'm not an expert in BD stent because I've just started using the stent only recently. So this is, I'm just sharing my limited experience on BD stent for TB-associated stenosis. So there are many causes of benign airway stenosis. The most common ones, post-intubation and TB, and I think in the West, they deal with post-intubation stenosis, but in Asia, we deal with both, actually, post-intubation and TB stenosis, and there are many other causes of benign airway stenosis. So the tracheobronchial stenosis or TB stenosis due to TB was first described in 1689 by Richard Morton, and it tends to be under-recognized and often misdiagnosed as asthma, and even after a standard anti-TB chemotherapy, the airway narrowing usually responds well, and a little subclinical airway narrowing remains, but the stenosis may develop during treatment. The term I use is acute phase TB stenosis, or many years later, and this is the term that we are more familiar with, post-TB stenosis. And this can cause major airway obstruction despite adequate anti-TB chemotherapy. So the standard anti-TB chemotherapy does not prevent the development of TB stenosis. And so the term TB-associated stenosis covers both, whether it happens during treatment, which is called acute phase TB stenosis, or years later, which is called post-TB stenosis. So the incidence of residual airway stenosis it can be up to almost 60%, and in the Hong Kong series, 18%, and we heard from Dr. Titiwat, the left main bronchus is the commonest site. And the incidence of severe airway stenosis is at least around 14%, and there is no way for us to predict which patient or when they will develop airway stenosis associated with TB, and therefore early diagnosis is important to control the obstructive symptoms. And then straight away to the treatment, already mentioned by Dr. Titiwat. Ideally, of course, surgical resection and reconstruction is the preferred therapy for tracheobronchial stenosis. But in my experience, in majority of cases, surgery is not feasible for for various reasons, such as patient refusal and the anatomical limitation, such as long segments, with Malaysia, severe stenosis, multi-level stenosis, and inadequate pulmonary reserve. Many of our patients in this part of the world tend to present late, and so they end up with poor lung reserve. And all these cases of TB stenosis are always discussed in our MDT with our cardiothoracic surgeons, and most of these cases, majority of the cases are not suitable for surgical resection, unfortunately. And then complication of surgery, such as anastomotic leakage, leading to reanastomosis, and airway recurrence of airway stenosis also happens. And just to illustrate the point there, this is a young girl, a case of post-TB stenosis. We referred the case to our thoracic surgeon who performed airway resection. You can see the sutures there. But there was recurrence after surgery. And then so we had to go in and dilate the tracheal stenosis. And then, with difficulty, we put a tracheal stent there. That was the final position. And then we even stitched the stent to prevent migration. And after 13 months, that's how it looked like before we removed the stent. And with a lot of difficulty, with challenges, we managed to remove the silicone stent, and this is what it looked like. And fortunately, the patient was well. So that's a good story, and she didn't develop significant granulation tissue over 13 months. So that's a good story. But you can understand the challenges that we face when to deploy a silicone stent and to remove the stent, subjecting her under general anesthesia. So what are the endoscopic approaches? Now we know that majority of cases are not suitable for surgery. So again, mentioned by Dr. Titiwat, the most common procedures that I perform in my place are balloon dilatation and mitomycin C and stenting if dilatation doesn't work. So indication for endoscopic intervention, we know progressive symptoms, recurrent post-obstructive pneumonia, and abrupt collapse of one lung. And just to illustrate the point, everyone familiar with the procedure, balloon bronchoplasty under general anesthesia via rigid bronchoscopy. So, but then recurrence happened. It's not uncommon, that recurrence occurs after dilatation due to mucosal trauma. And then mechanical dilatation alone might be ineffective to maintain the airway patency. So what do I do in my place? So I apply mitomycin C after balloon dilatation. Some people don't believe in mitomycin C, but I still use it. So we have heard from the previous speaker again about mitomycin C, so I'm not going to spend a lot of time on this. So we know that the mitomycin C has shown some benefit in delaying recurrence of benign airway stenosis, such as post-intubation tracheal stenosis. But the use of mitomycin C in post-TB stenosis has not been well described. Although not many people believe in mitomycin C, we did publish a couple of case reports showing the success story using balloon dilatation and followed by topical mitomycin C without the need for airway stenting. So what about stent in TB stenosis? So it is inserted into the airway for airway remodeling, and the indications are when the stenosis recurs after balloon dilatation and mitomycin C, and if there is a significant tracheomalacia or bronchomalacia. And we know that silicone stent is usually used in TB-associated stenosis. So what are the type of stent? We are familiar with silicone stent, metallic, 3D printed, and then the one I'm going to talk about is a biodegradable stent or BD stent here. So we know that the pros and cons of silicone stent. It is the preferred stent in benign airways disease such as post-intubation and post-TB stenosis. And I think our colleagues in Korea published a lot of papers on silicone stenting in TB stenosis. And you can cut it. Easy to remove? I'm not quite sure. I think that's relative. If the silicone stent has been there for many years, it can be quite tricky to remove. And these advantages of silicone stent, I think migration is real, and granulation tissue. It can be your nightmare actually when when the stent has been inside you for many years actually. And then of course you need rigid bronchoscopy to deploy a silicone stent and then to remove the stent. And then I think we having seen a lot of TB stenosis, we know that the airway stenosis can be really complex. And then and the deployment of the silicone stent, even removal of the silicone stent in TB stenosis can be quite challenging and even, I think, hazardous to the patients. One case that, again, a young girl with tracheal stenosis secondary to TB, and we put a silicone stent inside the trachea. We even stitch it to prevent migration, and as you can imagine, there's a lot of work actually. And it can be really challenging to put a silicone stent. And so now I'm coming to my topic now. So beyond silicone stent for TB stenosis, what else can be offered when silicone stenting is not feasible in TB stenosis? So I propose, perhaps we can consider biodegradable stent in TB stenosis. It is a self-expandable, degradable stent, uncovered, made of polydioxanone with radio-opaque gold markers, and it's the same material that is used in surgical suture, and it will degrade after 3 to 6 months. And it's already being used in benign strictures like lung transplant, airway stenosis, and post-intubation stenosis. And I didn't manage to find any papers on BD stent in post-TB stenosis. So could BD stent be an alternative to silicone stent for TB stenosis? So these are the potential advantages. Number one, removability. So benign conditions sometimes need temporary stenting, such as TB stenosis, and then silicone stent removal needs general anesthesia and can be technically challenging. And BD stent will gradually degrade and eventually vanish from the airway, and this could avoid long-term complication of permanent stent. And then it also can avoid technical issues, such as in TB stenosis, sometimes the anatomy can be really complex and the lumen is small, like what Dr. Titiwat mentioned. Sometimes you can only dilate so much, and if you try to dilate more, you might cause rupture or trauma, tear of the mucosa. So sometimes, in that case, we won't be able to put a proper silicone stent because of the small lumen, the airway, right? And so this BD stent is custom made, so it's patient specific in terms of the diameter and the length, and its uncovered design reduces the risk of migration and allow mucociliary cleaning function, and so overall it reduces the number of interventions. So you don't have to remove it, you don't have to put the patient under general anesthesia, and the potential reduces the potential iatrogenic injury risk. And this is what it looks like. Not my work. This is what it looks like when we put a BD stent and this is what it looks like after it degrades. Okay. So there's no need to remove it. So it is attractive to us who deal with TB stenosis in this part of the world. So what about data from the literature? I just pull out one paper published in Respiration. Just focus on the first study there. Not many patients, 6 adults, and they put 20 BD stent, indication anastomotic stenosis after lung transplant. So basically, no complication was seen during the stent placement. 4 out of 6 patients needed multiple stenting for anastomotic restenosis. Median time to any restenting was 5 months. 1 patient died of pulmonary embolism, not related to the procedure, and the remaining 5 patients were in good clinical condition for up to 4 years since the first stenting, and they were intervention-free for up to 44 months. Okay. What about the experience in pediatrics? I don't do intervention in pediatrics, so basically, based on the papers, the BD stent seems to be favorable even in pediatrics. And so it's custom made, so it can be as small as from 5 mm, the diameter, to 25 mm. And that's the delivery system, almost something like the delivery system for metallic stent, I think. But the stent needs to be loaded just before implantation. Okay. Something like endobronchial valve. I think you need to load the endobronchial valve before implantation. Right? But all this, the loading procedure can be learned. Actually, it's no issue, not a problem. And so this is what I do normally. The request form. So we will put there the exact length or diameter of the stent, and then the manufacturer will come up with the stent that we request. Okay, just to show you the first case that we did in December last year. Short video. We did this procedure via rigid bronchoscopy under fluoroscopic guidance. You can appreciate the radio opaque gold markers there, right? And this patient is a young patient with post-TB stenosis affecting the right main bronchus, failed dilatation, failed mitomycin C, not suitable for surgical resection. And as you can appreciate there, the lumen there of the right main bronchus, the ostium was very small. Okay, and we could only dilate it so much. And so this is what we did. We dilated it first. And you can appreciate there the post-obstructive pneumonia, after we relieve the obstruction there, a lot of secretion coming out after we did the dilatation. And then we attempted to insert the BD stent. We introduced the delivery catheter, but at this stage it was still too tight. So what we did was we dilated it further using a balloon. And once we felt it was big enough, then we introduced the stent, the BD stent with the delivery system via the side port of the rigid bronchoscope. And we put it into the right main bronchus there, into the ostium. So the deployment is almost the same as a deployment of a metallic stent, I think. And so that's what it looks like after deployment. It was a bit, distal. So what we did was we used a flexible forceps to pull it out a bit. All right, so this is what it looks like, the final location of the BD stent there. All right, and then we did the surveillance bronchoscopy about 1 month later, so you can appreciate the lumen there is still patent there. I think maybe the proximal part of the BD stent has already degraded, okay, and the patient is well. All right, so and there was no need to remove the stent. So this is my last slide. In conclusion, benign symptomatic central airway disease may require temporary stenting when dilatation fails or when surgery is not feasible. And the use of biodegradable stents could avoid long-term complication of permanent stent. BD stents, to me, might be an alternative to silicone stent in TB-associated stenosis, as it offers ease of deployment in complex TB stenosis or Malaysia and doesn't require removal. And so you don't have to be a virtuoso to deploy stent. So this is a slightly easier method. So, but however, when you put a BD stent, some of these patients may need multiple stenting, like the paper for lung transplant patient. Then some of them might need multiple stenting before the airway becomes stable, actually. And I think more experience is needed to establish the use of biodegradable stent in TB-associated stenosis, because really I couldn't find any papers on BD stent in TB stenosis. Lots of papers on silicone stenting in TB stenosis. So I think this is a good opportunity to establish the efficacy of BD stent in TB-associated stenosis. And since in India there are a lot of cases of TB, just like in Malaysia, maybe we can work together with our colleagues in India, to collect data on BD stents in TB stenosis. All right. Thank you very much. And if you have any questions, you can email me. So we don't have time for Q&A here. These are my references. And my very last slide, I would like to invite all the delegates here to attend APCB in Malaysia in May this year. I understand there are 1,000 delegates in BRONCHUS, so maybe half of them can attend APCB in May in Malaysia. Thank you very much.